Welcome to Wednesday Yachting Luncheon, live from the virtual grill room of the St. Francis Yacht Club. We hope that you and yours are sheltering in place in a comfortable environment, and we look forward to greeting you at the Yacht Club and especially the grill room just as soon as health conditions permit. In the meantime, we're going to use the Zoom format to have interesting speakers from all over the country. Our speaker today is related to former Sailor of the Year Bruce Stone. Our speaker was born in Providence, Rhode Island, and in fact took his Boston Whaler from Sausalito to San Francisco this morning in his morning commute to work. So he crosses the bay every day in a Boston Whaler. He first got on a sailboat while a sophomore at Harvard when he responded to a crew wanted ad. And he responded saying, yeah, I'm an experienced crew. And so he signed on to a CNC 33 at a Corinthian Yacht Club in Marblehead and raced on that boat. Went on to become a medical student at North Carolina, Chapel Hill, where he met then a potentially interesting date who was invited on a trip to the BVI. And after 10 days of cold, wet, uncomplaining partnership, he knew he had the right person to seal the deal. Since that time, he and his family have taken cruises with the family in charter boats every year to Maine, up and down the East Coast, to the BVI and Europe. So you know that a family learns a lot when they sail together. And he went on to do internship and residency at Harvard and Stanford, and remembers the first time he took up windsurfing in the 70s. He switched over to a stand-up sailing and said he liked it a whole lot better because the crew would finally listen to him. And he considers Navrana to be the first time he jibed in front of the grill room in his windsurfer. Those of us who remember jibing in front of the grill room is a genuine thrill. Can imagine doing so in your windsurfer, all the more of an adventure. At any rate, we're very pleased to have a good sailor and a really thoughtful orthopedic surgeon give us a talk today on knees and sailing. Kevin, welcome to the Wednesday Yachting Luncheon.
Thanks so much, Ron. It's great to be with you and your entire sailing community.
Great to have you here. Fun slide. Heck of a background there.
There you go. So listen, Ron, life is short. There's only so many windy days in any given knee. And if you were to sit down and talk with me and said, hey, what can I do to keep sailing? I want to stay on my boat. I've got a sore knee. I'm going to take you through a whole program today of what you can do for yourself, what we can do to you, how to keep you sailing forever. So first, let's do a little comparison between knees and sailboats. So when you buy a sailboat, you enjoy it until it breaks. You do preventive maintenance. You lubricate squeaky, rusting parts. You repair the broken ones. You replace like with like. You improve the boat with each breakage, hopefully adding a better part. Well, knees are no different. So let's start with a little bit of knee anatomy. First of all, you've got your thigh bone, the femur. You've got your shin bone, the tibia, the fibula on the outside, and the patella up front. And these bones are all connected by ligaments. And you can think about ligaments as the stays and shrouds of your knee, just like your sailboat. So when the ACL is torn, as you've all heard about, and some of you have had, the tibia shifts forward, called a pivot shift. The knee is unstable, same as if you ruptured it on your sailboat. The PCL, you can think of as the aft stay. Usually it's damaged when you jam the tibia into a lazarette with a sudden stop. And the MCL and LCL, you can think about those as the shrouds on the side of the knee. Fortunately, when those are torn and injured, they often will heal on their own. The meniscus is the shock absorber for your knee. It's a fibrous tissue, has great blood supply. The tragedy is that it's torn over 1 million times a year in the US alone, and surgeons most commonly take out the torn tissue, and that dooms the knee. It dooms the knee to arthritis. And the knee itself is surrounded by a capsule and synovium. The synovium has the cells of the joint, and those cells produce synovial fluid, and they secrete compounds that are called cytokines and growth factors. And we're going to talk more about that today. When you get a swollen knee, it's thickened, inflamed tissue, excess fluid inside the knee. The articular cartilage is that white, shiny bearing surface on the end of the bone. It's called hyaline cartilage because it's glassy-like. And it's covered by a lubricant, and that lubricant permits your knee to last a lifetime of running or sailing in rough water if you're not injured. There's no natural healing once that articular cartilage, that bearing surface, gets injured, and that's where the beginning of arthritis starts. So if we dive into arthritis, what's arthritis look like? Well, if you think about bearing through the gel coat, or here the hyaline articular cartilage down to the bone, that's what arthritis looks like. And if our goal is to fix your knee and help you stay on your boat and keep you sailing, we have to repair that damaged articular cartilage. So you can think about it, if you damage the cartilage, it's like a tire getting down to the steel thread, or it's like mismanaged teak on your boat. Unoiled, it dries out and gets creaky. It fails to tolerate the impact of repetitive loading or banging on the waves. And so, you know that new boat smell, fresh from the factory? Well, boats and knees are somewhat similar in that way. Everything's supposed to work, yet nothing works quite as well as it could. And the most common reason we see from knee injuries leading to arthritis is actually operator error. And so the first thing I can counsel you on, Ron, if you want to keep your knees going, is to think about avoiding those self-induced injuries. So let's take you through a 12-step program to keep your knees on your boat. Now, I know you may, and other sailors in the community today may be used to a different kind of 12-step program, but this should all sound kind of familiar. So here we go. To sail forever, you need to do several things. One, you need to treat yourself like an athlete in training, not a patient in rehab if you get injured. And your goal needs to be to return yourself fitter, faster, and stronger than you've ever been in years. So you use your knee injury as an excuse to get better than you've ever been. And the methods to do that are to do the maximum number of things for you and the minimum number of things to you. That's our goal. And we want to keep you biologic as long as possible. So as we slide through these slides, we want to keep you biologic. If we have to make you bionic, meaning using artificial materials, then we want to use ones that you can play sports on forever. And again, the ultimate goal is to have you drop dead at age 100 at the helm. So let's talk about the 12-step program to getting you there. So first of all, remember I mentioned operator error. First thing you can do to really keep your knees on the boat is avoid distractions. Leave the cell phone at home. Keep your head in the game. Pay attention to what you're doing. So many of the injuries we see are, I was going too fast, I wasn't paying attention, I was distracted, I made that error. Those are avoidable injuries. Step two, you can always optimize your nutrition and your weight. So first of all, fuel your body with protein. Protein is the core building block of your muscles. Leave the fats and carbohydrates as treats. Focus on protein. And today, these are usually plant-based proteins because they have so little fat or no fat and are quite optimized for building muscle. And then optimize your weight. And here's why. You take 2 to 3 million steps per year at up to 5 times your body weight. So if you lose 10 pounds, that's up to 50 pounds, 2 to 3 million steps per year. It's an enormous amount of force off your knee joint. And here's how you do it. Use water as portion control. First of all, take 2 glasses of water before you lift the fork, 2 before bed, 1 glass of water between each alcoholic drink. So when you're standing at the bar at the St. Francis and you're having your second drink or ordering your second drink, order that glass of water first, down the water, and then do the drink. And of course, no exercise, no eating between meals, and exercise daily. That's 7 days a week. And that's how you'll manage your weight. Step 3, fitness. An hour a day of fitness exercise, at least 20 minutes needs to be high intensity if you really want to build muscle and build bone and really stay on that boat. Also, flexibility really does matter. Tight joints are the ones that get injured the most. It's worth it to do that stretching program before you get on the boat. It's worth it to think about flexibility. Lastly, strong muscles mean less force through the knee because the muscles absorb the force in walking and running. So it's worth it to do weight training and build your musculature. And that applies directly to your bone. As you know, we're all getting a little osteoporotic as we get older. That means the bones are losing bone mass. The only way you can safely build bone mass is resistance exercise. So hiking up hills, lifting weights, that's what builds bone. That's what prevents osteoporosis, and that's what keeps you on the boat. So now let's shift over to the things that we do to you as opposed to all the ones that you can do for yourself. So let's start here with lubrication. There are lubes and there are lubes. In this case, we're thinking about lubes for your knee joint, and there are two major kinds, hyaluronic acid and lubricant. The cells of the synovium that we talked about earlier, they produce the natural lubricant of the joint. Also, roosters, and now genetic engineering, can produce that same lubricant. We can inject it into your knee to add lubrications to a creaky joint or an arthritic joint. Eating hyaluronic acid doesn't work. We don't want you to sail on squeaky joints, so lubrication has become one of the key tools in our armamentarium to keep you on your boat. Step 6, inflammation. Inflammation, as you all have heard, is sort of the common pathway of all diseases, whether it's cardiovascular disease, Alzheimer's, or arthritis. And so these days, we're very focused on shutting down excess inflammation. But we don't want to do it with the traditional Motrins, anti-inflammatories, and certainly not cortisone, because cortisone, while it shuts down inflammation, inhibits cell metabolism and actually damages the tissues that we're trying to save. So now we want to use specific growth factors and things called cytokines to stimulate those cells of the joint to produce more lubrication and growth factors and recruit the body's own stem-derived repair cells to initiate healing. So let's talk about that a little bit more. So what are the tools in this new anabolic era of orthopedics? They are taking some of your fat and getting the growth factors and cells out of that. PRP, which is your bloodstream, you take the platelets there that are rich in growth factors. Bone marrow also has the same things. Or today, what we're most excited about is the amniotic fluid from healthy mothers at the time of C-section. And let's explain that a little bit more, but mostly you can say goodbye to cortisone. It's not the best choice for an inflamed joint. So what about this amniotic fluid? Well, let me explain a few things. Number one, the reason the mother doesn't reject the fetus, even though the fetus is only half the mom, is because there are specialized cells and growth factors in that amniotic fluid that shut down inflammation. They're called immunomodulatory. And they also are rich in growth factors and cytokines and self-repair cells, potent anti-inflammatories, antimicrobial. In a sense, the amniotic fluid is the fountain of youth, and we want to use it now to our advantage. What we want to do is take an arthritic joint and shift it from being degradative or breaking down environment to anabolic or building up, stimulating the cells to produce what we want them to produce and be a healthy joint. And we found in studies that we've done here at the Stone Clinic and Stone Research Foundation that if we give a single combined shot of lubrication plus growth factors from amniotic fluid plus the PRP growth factors from the blood, we can get 6 months to a year of pain relief from a single injection. And this is fascinating data that we're now expanding the study on, but really these are potent tools that are safe to use. Now listen, Ron, if you limp, you can't sail fast. So you've got a few options here now. What happens if we have to fix your knee? Well, we can fix it one of two major ways. We can either use biologic tissues, where we replace the articular cartilage, meniscus, and ligaments, or repair them, or we can use bionic tissues, where we just replace or resurface one part of the knee or the entire knee, which we've now totally reimagined, and we'll show you how we do that. So first of all, the first thing to understand is that if you come to me, Ron, early enough, and your joint space looks like that x-ray on the left, where it's open joint space, that dark space between the femur and the tibia, then I have all my options available to me and to you for biologic tissues. I can put back your missing meniscus that you tore when you were playing high school soccer. I can put back ligaments. I can regrow the cartilage. If, however, you come to me and it's too late, in a sense, the joint space is closed, it's bone on bone, as you see in that x-ray on the right, then I can't put in a new biologic tissue there. There's just not enough space. But I can repair just the part that's down to bone and not have to do a full knee replacement. So let's look at that. So surgically repairing injured tissues as early as possible is the whole key. So our bias for repairing articular cartilage, that bearing surface that you're now so experts in, essentially the gel coat on your boat, is to do a technique called articular cartilage paste grafting. So the old thinking was that the cells in the articular cartilage couldn't heal. And we said, why not? We can grow these cells in tissue culture. Why can't we grow them inside the knee? And so we have this technique of pasting on. It's like grouting a hole in your wall where we create a bloody bed and add the articular cartilage paste. And without grossing you out, I'm going to show you a quick little video that shows exactly how we do that. And there are other techniques too of doing cartilage transplants, but we're quite biased towards this paste grafting technique. So here's a little short video. Now, this is the surface of someone's femur. So think about that damaged area that you see where the ice pick here in the knee is pointing to it. That surface is dead bone. And as I place the ice pick into that dead bone, the bone falls away out into the joint. So that's a defect in the surface. That's what arthritis looks like. And the only way to really repair it is to essentially create a bigger hole to stimulate the blood supply from the bone marrow. And we want to stimulate a big, robust healing response here, not a little microfracture. The old technique of microfracture is to make a few little holes. We now know that that doesn't work well enough. We need to aerate the entire lawn. So if you look at this, it looks like a putting green where we've now made lots of holes. Then we come in the knee to a place where you don't need it, the intercollar notch where the ACL goes by, grab a plug of cartilage and bone, take it out of the knee, smash it into a paste, and then pack it into this defect. So just like grouting a hole in the wall. So we're now adding these cells and adding growth factors to this paste in order to stimulate a healing response. Let's take a look at what that looks like 1 year later. So here's a year later. The surface in that knee has healed beautifully. We replaced the missing meniscus. So now this patient has a biologic joint replacement rather than an artificial joint replacement. Let's go on to the next one. So now you know that both meniscus and ligaments are now off the shelf, meaning Amazon doesn't quite have them, but there are tissue banks all over the US that receive these tissues, and we can take advantage of those tissue banks and get tissues for your injured or arthritic knee. So for the meniscus, when it's injured and damaged or someone's taken it out in the past, we can pop in a new meniscus from a tissue bank. And here's what that looks like. Here's the articular cartilage, which looks healthy in this knee on your left. Here's the meniscus transplant in the center. And then here it is popped into that patient's knee to act as a new shock absorber. And so often I get a phone call from a patient that says, hey doc, isn't there just a shock absorber you can put in my knee? I'm not ready for a knee replacement. I'm not ready to give it up. I want to sail forever. I want to run forever. So here's an example of a 73-year-old guy who comes in. He's got his Death Valley race belt on. He runs 100-mile and more races. He said, hey doc, I just want to keep running for a while. I just need a shock absorber. So we pop in a meniscus into his knee, and he keeps running for another 4 years and sends us these wonderful notes about his running career being continued. And again, we can do that as long as he comes in before it's bone on bone. So let's think about the ligament. You all hear about ACLs being ruptured all the time. Our bias now is to use bone, patellar tendon, bone tissue from the tissue bank, not from you. We don't want to take your patellar tendon or your hamstrings anymore. We know that weakens your knee. We know that that leads to arthritis. And so we want to use these donor tissues, and we want to add growth factors and cytokines to them so that we can accelerate their healing response. Why is it when you see an injured athlete and they get an ACL, it takes them a year to come back? It shouldn't take a year. We should be better at accelerating that healing process and the rehab process, and that's the research we're working so aggressively on. So let's look also on what you do now when it's only one part of the knee worn out. So here's this x-ray. You're now all pros at this. You look at this, you see the joint space is open on the outside by the fibula there, but the inside is down to bone on bone. And so many patients call us up and say, hey, I've been told I need to have a knee replacement, a total knee replacement. 80% of people in the world told that they need to have a total knee replacement do not. They could either have a biologic replacement or they could have a partial, because most of the time the entire knee isn't worn out. It's usually just one side. And so outpatient partial knee replacement, number one, gets you back on your boat faster. There's less surgery, quicker rehab. The knee feels much more normal. It becomes a forgotten knee usually by 3 months. And we don't limit our patients' return to sports, running, and other activities, sailing aggressively on these partial replacements. Let me show you what's changed that's made this so possible. What's changed is the robot. So now we can do a CT of somebody's knee, build a 3D reconstruction, and show where we would put these implants before we ever touch the knee. So we can optimize the placement. So at surgery, we can make a pretty small incision, just burr away where the implant would fit. The patient's usually worn that part away already. And then again, as an outpatient, we can pop on this cap over the femur and over the tibia and resurface that worn out space. That piece of plastic there acts as the new meniscus and gives them back a healthy and active knee that they can play sports on. So here's what that looks like for the medial side, which is the most common area where people wear it out. And so that top row, if you see the bone on bone, and then on the right, you see that medial replacement. The middle row is the lateral side or outside of the knee. And then you can also just do the isolated patellofemoral. So many people have worn out their kneecap that we just go ahead and resurface just the kneecap and the top of the femur and not touch the rest of the knee. Now, in patients who are active and athletic, as most of ours are or want to be, you can see in this particular patient who went and did 500 miles on his partially replaced knee and just had no pain. And that's the kind of story we love to get back and hear, and that's our goal. Now, what do you do when it's really worn out all the way across the knee? So you see in this x-ray now, there's no joint space. That staple is there from an old surgery they had in college. We do this 3D modeling that you see rotating on your right there. It shows arthritis throughout the entire knee. And then we can use a totally different kind of implant. So total knees for sailors and for athletes shouldn't be your father's and your grandfather's total knee. It's changed. What happened in the older total knees was that they were cemented in place. And what happened with activity and aging is that the cement would come loose. So the new concept is to use, number one, bony ingrowth components, and number two, plastics that'll last 30 years are called high molecular weight polyethylene. And let me show you a picture of what this looks like. So the undersurface of these new implants is porous, and your bone is alive. And so your bone can grow into these little interstices and fix the implant right to the bone with natural healing. Then we never have to worry about you knocking it loose. So if you want to go back and run and sail hard and play hard, we don't worry about it anymore. We encourage you to do so. And so here's what that looks like. This is an uncemented knee replacement where the femur has replaced the cap on the femur has replaced the worn out area there, tray on the tibia, and the clear space in between is that high molecular weight polyethylene. So many patients ask us, hey doc, can I go back to running? We've never seen one of these come loose from sports. So why not go back? Push the limits, enjoy it. Life's short. We want you to drop dead at the helm at age 100. So train and go for it. Speaking of training, step 11 of our 12-step program is rehab like there is no tomorrow. Again, see yourself as an athlete in training, not a patient in rehab. Focus on more than just your knees. There's no arthritic patient who comes into our clinic having had years of knee arthritis, who doesn't have a stiff hip and stiff back and limitation on some of their motions. They've walked on the other side of their joint for a while, and just all of them are, all their body is a little bit abnormal. So it's critical to get the physical therapist and the trainer together to focus on a total body fitness program. Core and trunk muscles really do matter. And again, it's daily exercise, just as we started out the presentation, and 7 days a week. And I have to remind you, never, ever, while watching TV or reading. The reason is you have to feel your heart rate. You have to feel where you're breathing. You have to feel where your muscles are starting to get tired and push them past that point. If you're distracted by reading or watching TV when you're working out, you're missing out on half of the workout. So I totally encourage you 7 days a week. And the reason for 7 days a week is to build the addiction that you get from hormones, from adrenaline, from testosterone that flow when you exercise and you push yourself a little harder each time. Remember the goal: fitter, faster, and stronger than you've been in years. Step 12, play. Don't stop. The whole goal is to push yourself and keep playing forever. So here, Andrew Holsworth, a great sailor that you all know well in the club, just came in, had these various injections and factors, and went on to win a whole host of championships. And is a great example of just never letting the injuries slow you down. So our goal is to have you play forever. As you know, 70 may be the new 50, but your tissues are still 70. So we want to take the strongest tissues that we can get and build upon them and build upon that platform. We want to add anabolics, growth factors, cytokines to help accelerate the healing and build new tissue. And we want to use artificial materials that will integrate into your bone and tissues so that way they're not knocked loose. So in summary, knee injuries, if treated immediately with soft tissue repair, regeneration, and replacement, can work, can keep you active, can keep you playing. Arthritis is actually fixable. It may even be curable in some days, and we're working very hard on the research side to do that. Biologic joint replacement, biologic joint replacement when the joint space is open, is a great option. Bionic joint replacement, whether partial or full, if perfectly placed and perfectly rehabilitated, will get you back playing sports. So don't live, there's no reason to live with a painful knee and think, oh, I'll wait till I'm older. Life's short, every decade's precious. Fix the pain, fix it early, and get back out there and play. So start your 12-step program today. Whether your knees or your sailboats are old or they're new, they need to be watered and loved. And lastly, I'll say, I've just written a book about this, so here's a shameless plug for that book. It's not out yet, but it will be, and here's a way that you can sign up and hear more about it. And the profits from that book are donated to the public nonprofit research foundation here called the Stone Research Foundation, and that supports the research that we're trying to do to push forward these technologies and keep you active. So I hope you can sail forever. Our job is to keep you on your boat, and your job is to work like there's no tomorrow on yourself first.
Wonderful, Kevin. Thank you very much. Great presentation. So a couple questions. One, hiking out on a laser, is what hurts or damages the knee in hiking out on a laser? Is it the loading or the stress of it? Is it friction of the knee parts? Is it shock? Or is it the underlying health factors that cause it not to be moist enough or nourished enough? What hurts your body when you hike out on a laser? Or maybe nothing does. Tell me that.
The most common complaint we hear from hiking out is anterior knee pain, meaning the patella, the kneecap, is overloaded in that position on the top of the femur. It's like doing a squat, in a sense, all day long, but with pounding of the waves. So if you think about just standing doing a squat and adding pounding to it, that's essentially what you're doing to the front of your kneecap. And so people get anterior knee pain. So the best protection there, of course, is strengthening, because the more strong the muscles are, the more they absorb some of that force.
Okay, so the cure, if you will, or the preventative activity is just strengthening, i.e. your exercise model. That's really what's going to help your knee in hiking out on a laser.
Yes.
Because it's automatically putting extra load on the knee.
Yes.
Okay. So when you say 5 times your body weight, what do you mean? You mean the point loading of the knee causes 5 times your body weight, the pounds per square inch? What do you mean by 5 times your body weight?
So when you stand on one leg, that's your body weight on one leg. When you step off a curb, that increases the force to the distance of the curb at some multiple of your body weight. If you run or you jump and land, the amount of force going through that single leg is about 5 times your body weight going through that joint. So if you lose the shock absorber of the meniscus, The force is then concentrated on a narrower surface on the top of the tibia, and that's what leads to the arthritis.
So it's PSI. You're saying there's greater PSI by the shock loading of landing or doing whatever you're doing when you're effectively running or doing what you're doing in exercise. So you said a couple times, you said don't use Advil. Talk to us about what's bad about Advil. I'm a guy who doesn't believe in any of these medicines, so I don't use Advil anyway, but that's the kind of amateurish perspective. Tell me, what's the medical reason not to use Advil or medicines like that?
So the short-term use of what are called NSAIDs, ibuprofen, naproxen, indomethacin, these types of drugs are quite safe. The long-term use of these drugs, however, decreases the collagen formation in the tissues that are trying to heal. And so the collagen that forms is more with scar tissue or not as strong. There's also, of course, risks to stomach acidity and ulcers. And so in general, we don't want people on these long-term non-steroidal anti-inflammatories.
And so what's bad about cortisone?
Cortisone's method of action is by shutting down cell metabolism, meaning the cells turning over. And so when it does that, it stops any tissue healing that can go on, and it has a direct toxic effect on the local cartilage. And so cortisone, while it's a potent anti-inflammatory, unfortunately weakens the tissue around. As anyone who's had a steroid or cortisone shot into their Achilles tendon or patellar tendon and then went on to rupture it knows these injections have really deleterious side effects and should be used very cautiously. We'd rather give you an anti-inflammatory injection that doesn't have any downsides.
So where does the repair tissue, you said you try to get repair tissue from healthy, younger patients. Where does that tissue come from? Who are the patients that are donating replacement tissue?
So unfortunately, young people die most commonly or often by falling off their motorcycles. And that kind of donor donates their cartilage and meniscus and ligaments to athletes who need them. Of course, their hearts and lungs and other tissues as well. So allograft banks or tissue donation banks are all over the United States and are high quality now. And so we can get tissues from these tissue banks.
So a speaker we're going to have in a few weeks is going to talk about China, and one little small part of her talk is about the tissue banks in China that are coming from involuntary donors. How does anybody in America make certain that they're getting their tissue from a voluntary donor, a genuinely safer place to get them from?
That's a good question. So I gave the first talk on meniscus transplantation in Beijing, and they asked me to review their tissue bank processes there. And unfortunately, they were using high dose radiation to sterilize the tissues because they weren't sure of the tissue supply, the donor population. Here in the US, it's very different. If you sign a donor card and agree to be a donor, upon your death, you're tested extensively for any infectious diseases. The tissue banks are all certified, and they go through a very rigorous process to make sure that those tissues are safe and sterile and available for use.
So when a young kid has an unfortunate accident and effectively dies on a motorcycle, and that person's agreed to donate their tissue upon death for these purposes, tell me the process from the impact person dies to when their tissues are saved someplace.
So there's a very formal process that I'm not involved in, but the tissue banks all have teams that go to the hospitals where people pass away. And there's a very rigorous protocol on checking to see whether or not there are any infectious diseases, whether or not the person has donated their tissues in advance. And I would encourage all of you to sign the form at the driver's license registration desk that makes you into a donor should you die. If everyone signed those forms, there would never be a tissue shortage in the US, not just for the orthopedic tissues that I want to rebuild your knees with, but also for the hearts and lungs and everything else that people are on waiting lists to try to get. So it's a real great public service if you can sign up, and encourage everyone to do so.
So from the time that the donor tissue gets in the lab or the tissue bank or wherever, does it keep growing? Do you have methods inside the lab to grow the tissue on this person's, now the deceased person's, knee muscles? How does it happen?
So the tissues in orthopedics that we use are dead, meaning the meniscus is dead, the ligaments are dead, the bone is dead. And what happened, and it's then it's frozen. And so we receive it in a frozen state. We then thaw it in antibiotic solutions. We then add growth factors to it from the recipient's own blood. And we use that infused tissue to rebuild their knee.
And so once it's in the tissue bank, and it's, how long will it usually stay there before it gets repurposed on a repaired knee?
Oh, I don't have their tissue bank data.
What would you guess?
Oh, anywhere from a week to 3 months.
Okay. There's no such case of, that it doesn't seem like 2 years or 10 years or long periods of time like that between the dead person.
There's a strong demand for tissues in the United States, and always a shortage.
So now robotic surgery, what are the advantages of robotic surgery? How is robotic surgery able to do what you, the surgeon, or other orthopedic surgeons can do, but don't do quite as well? Tell me what the advantages are.
So Ron, here's a confession. My robot is more accurate than I am. So for 30 years, I've been an orthopedic surgeon replacing joints. And so the first half of my career, we would use special saw guides that we attach to the knee to use to make our cuts to fit the artificial implant on. And the saw guides, just like a saw guide anywhere, are not always particularly accurate, or can vibrate, or can cause issues where you're just off by a little bit. In this case, millimeters really matter. So in a robotic case, the surgeon is still guiding the robotic arm. It's a haptic robot, which means that I can only burr or saw in the field that I've pre-decided on the CT scan and on the computer. So it permits me to make an extremely accurate cut, more so than you could ever do by hand. By being extremely accurate, when I put on the implant, it's fit perfectly tight to the bone, and the bone can then grow into it. And that's what's transformed joint replacement from the old days of using cement to now uncemented, fitted prostheses that permit you to go back to sports.
So in other words, the fineness of the cut and the accuracy of the replacement part to the existing knee requires no cement because you've got such a little bit of space between the old and the new part?
You could use cement if you wanted to, but you don't need to anymore because the bone can grow in.
Because it fits so well. And so once the replaced part fits onto the existing knee, does it start growing after it repairs, or does it start growing right away? What's the process by which it starts to grow into the existing?
So once we put a cap on the end of the femur, it takes 6 weeks for the bone to grow in fully and fix that metal cap to the bone. After 6 weeks, it's fixed. It's not coming loose, and you're just doing your rehab and pushing forward to doing things you haven't done in years.
Is that a stronger knee than the original knee at this point, or is it almost as strong?
Neither. There's nothing better than what you're born with, which is why avoid injuries if you can. If you get an injury, have us repair it as soon as you do, because if you live with it for a long time, you may push yourself over to the bionic side of our repair. And something artificial is never quite as good as the new version. So we are not at the point yet where we can put tissues and implants in that are better than you are. We can help you become better by fitness training and everything else, but the implants are not better than you are. So we really are strongly encouraging you to fix it early, stay active, and use the right implants when you need to fix it.
So nextly, I'm curious about how the technology has changed the workaday life of Kevin Stone. 30 years ago, give me kind of like a week in the life of Kevin Stone, and then compare that to, next week.
Sure. So I divide my life between clinical practice, where I'm treating patients, not-for-profit research. We have a public research foundation where we're doing research on all of these techniques to make them better. And then for-profit research when we invent things that companies take and sell, or we do startup companies. So what's changed from 30 years ago is that in the past, all of my joint replacement patients, even biologic joint replacement patients, would stay in the hospital. And so I'd be making hospital rounds. Today, almost every procedure we do is an outpatient procedure, including the total knee replacements. They're all outpatient. They all go home the same day. They can put weight on it right away. They're in our clinic the next day training for 2 hours a day for weeks and months on end. The longer they stay with us, the better they do. So that's what's really evolved, is the shift from the in the hospital to outside surgery.
And so a week in the life of you now, what are you spending less time in surgery, and you're not spending time telling them to exercise more? How's it, you're just getting more patients handled? What are you doing that's different?
Yeah, so we're very driven on the research side. So anytime that there's more time, meaning our surgical procedures, I don't have to go to the hospital anymore, so there's more time on the research side. From May till October here in San Francisco, at the end of the day, I can be at the wall next to the St. Francis and on my windsurf board, which is a real treat living here. In fact, my car lives in the basement here of my building, which is in the marina by the Safeway. And in 20 minutes, I can be to the St. Francis and in the water, rigged and gone. So we've gotten more efficient over the years. And so in combining clinical care and play, it's important for me to play forever as it is for my patients.
So post-surgery, why is and how does exercise improve the healing process?
So when you exercise, you're raising your heart rate, you're circulating blood to those healing tissues, you're releasing testosterone, hormones, and pheromones, and adrenaline, all the things that make you feel good about your injury, make you feel better, feel less pain, getting your function back. All of those things really accelerate your healing. If you go home and stay put, depression sets in after every big injury or any big surgery, and we want to avoid that tremendously. One of the major research studies that we have going on that may be of interest is that we're trying to prevent the atrophy that patients get after surgery or after a big injury. And we have a study going on now where we'll give a patient testosterone just before surgery in order to block the receptors. You see, when you have surgery, you have a huge stress response, a release of cortisol, and that cortisol binds your muscle receptors, and within 8 hours, you start developing muscle atrophy. And we're trying to find out if we block those receptors with a single dose preoperatively of testosterone, then 1 month later, can we stop the atrophy that you get from every surgery? Because if you ask an athlete, what was worse, the pain from surgery or the atrophy that they took a year to come back from, it's always the atrophy. So if we can stop that, it'll be a big change for a lot of people.
So what's the worst knee accident that a patient has had?
Knee dislocation is probably the worst, where all the ligaments are ruptured all the way 360 around the knee, and we've got to rebuild them all at the same time.
And what was the cause of that particular accident?
Usually they're very bad ski falls, or friends hucking themselves off a 60-foot cliff, or falling into a crevasse. The things that take tremendous amount of trauma, car accidents as well. So from sailing, we're usually just seeing torn meniscus, torn ligaments from twisting, sore backs, a lot of which could be prevented by following the things we talked about in this 12-step program.
You say prevented because you'll strengthen the ligaments, strengthen the joints. Why would the exercise be preventative?
First of all, keeping your head in the game so you're focused on what you're doing. Stretching matters, strength matters, fitness matters. And so those things, and good nutrition, optimizing your weight. You can keep yourself healthy and out of my office if you do most of those things every day.
So now we watch football games. My goodness, I see knees bend and twist in those most amazing, scary accidents that you see on a football field. Talk to me about those kinds of tears and or bends.
They're no different than every other. They're just higher impact sometimes. And so with the ligament rupture, they'll often have significant bone contusions or fractures, and we simply rebuild what's broken. And the sooner we rebuild it, the faster they can come back. And now with growth factors and cytokines and lubrication, we're hoping to bring them back earlier. We feel badly in a sense that we're bringing them back earlier to do more damage to their knees, but that's their sport and their choice and what gives them pleasure, and also income. So we're here to help.
So give me a success story. Tell me about an unbelievably tragic accident, but which turned out to be the rehab worked out and the patient survived to be physically active again.
So we had a rock climber in the office this week who fell, was stranded for quite a while, lost all his toes, dislocated his ankle, injured his knees. And so this was now a few years ago. We rebuilt his ankle, rebuilt his knees. We saw him this week as he was coming in for his annual lube job. because things are a little creaky each year, and he's still rock climbing and doing the things he loves. Interestingly, he does it without toes on one foot, but still has stayed active and doing the things he loves to do.
How far did he fall?
Oh, I don't have his exact fall at the time, but I know he was stranded in a crevasse-like space for hours before he was found and brought out.
And so you said that the accident happened a while ago.
Yes.
Tell me the difference between fixing it, getting repair, seeing the doctor right away, and waiting a long time to get your visit with the orthopedic surgeon.
So if I see you right away after your knee injury, so much of the time I can repair the tissue. If you tear your meniscus, very often I can repair it. If you wait, the tissue gets beaten up and the surgeon most commonly takes out the torn tissue. So the difference between an early repair and late treatment is you can save the torn tissue, and that's often true for other tissues around the body as well. So listen to your knee. When it's talking to you, it's talking to you. And when you know you've injured it, you intuitively know. It's so much better to find out. So if I hear the story, Doc, I twisted my knee, I heard a pop, my knee swelled, you have a 98% chance of having torn either your meniscus, damaged your articular cartilage, or your ligament. Those three things together are what we call pathognomonic, or indicative of a tissue that needs to be repaired.
So what's the mission of the Stone Foundation?
So our mission is to learn how to accelerate healing, treat, cure, and hopefully prevent arthritis. And so all of the research is directed towards those things, where we're working on these growth factors and others to accelerate healing. We're working on better tissue replacements and arthritis treatments. We teach fellows, students, and interns from around the world. We lecture around the world, and we create videos and articles and now a book in order to teach these techniques to other surgeons as well.
So if a person wanted to be part of a study or otherwise contribute to Stone Foundation, what should they do?
Go to stoneresearch.org, and all the information is right there.
So how long can you continue doing what you're doing?
I hope forever. I want to play forever, but this work is what gives me tremendous pleasures as well. I love seeing someone like you come in with an injured knee and have you get back out on your boat.
So what's the age of retirement of an orthopedic surgeon? I ask this question because, as you know, I have a main sheet trimmer, Dr. Richard Russman, who is an orthopedic surgeon, and he says to me the technology keeps changing at a rapid rate.
Yes.
He feels that staying current in the technology is the gating influence of his practice.
It's interesting because what I'm finding is that the technology is augmenting me as a surgeon and making me a better surgeon. So I can combine my 30 years of experience, our research protocols, and our knowledge about what we can do for the patient today, as well as what we're likely to be able to do for them tomorrow. And that, combined with better surgical techniques, robotics, AI, which we're using to do database mining, gives me better tools and makes me a better surgeon. So every year I'm getting better and better, which I'm still enjoying quite a bit.
Give me a hypothetical mistake that an orthopedic surgeon can make.
Most common mistake an orthopedic surgeon makes is they don't listen to the patient. And the most common complaint a patient says, leaving an office where they're unhappy, is he didn't spend enough time with me, he or she didn't spend enough time with me, didn't answer my questions. So the patient most often knows what's wrong with them, their intuitive sense, even if they can't put the right words on it. If you listen carefully, you usually can get to the right diagnosis, and picking the right treatment for the right patient matters tremendously. So if a patient's not willing to do the rehab, not willing to put the time in, sometimes it's not a good idea to do a surgery that might be helpful for them, but if they don't do the rehab, they could end up worse. And so having that bond between the surgeon and the patient, it's sort of a contract saying, I'll give you my best surgery, you have to give me your best effort at rehab. And if we do that together, the patient's doing incredibly well.
What's the most common misunderstanding that a patient has about orthopedic surgery?
Probably the most common misunderstanding, I would think, is that it's going to get better tomorrow. That they misjudge how long it takes for tissues to heal properly, and they misjudge the amount of work it takes to really get back fully. And they also underestimate how much they've compensated for their injury, how much they've limped a little bit, or they have adjusted to their disability. They don't realize what a setback it is in their whole life.
So how many visits over what period of time does it take? Give me the anatomy timeline of an injury.
So when a patient gets injured and calls us up and comes into our clinic, we usually see them on a Monday, repair it for them on Tuesday, and then have them, especially if they've flown in from Europe or Asia or wherever, have them stay near the office in a hotel or condominium and spend 2 hours a day in our office with our rehab team. So an hour of straight classical physical therapy rehab, soft tissue massage, and an hour of fitness training every day that they're here, starting the day after surgery. So the goal is to build that program. And then when they leave, we want to work with them either remotely or directly with their own fitness trainer or therapist, and then have them come back at 1 month, 3 months, 6 months, a year, and then every year thereafter for fitness training, or come back more often if they want to for a fitness assessment. So we can help design programs for people to help them get better and better and better over the years. And so the more accurate we are in their testing, the more we push forward the science to be able to help them with things that we can do for them rather than to them, the better we are and the better they do.
So give me the org chart of your office with how many people in each of the given skill sets. How big is the total staff and what are the skill sets?
There are about 20 people here divided between nursing, MRI and X-ray, the fitness and rehab team, and the research team, as well as clerical staff, billing and coordination for patients, a patient concierge that helps them get their surgery organized and helps them bill their insurance and helps them find a place to stay, and all the things that are hassles for people in life we try to help them with. So
how often is there quackery? You know, there's lots of quackery that we see here and there on television about crazy cures and crazy, chiropractic techniques and stuff like that. How often do you see that in orthopedic surgery these days?
Oh, I don't know the answer to that question. I think that we're all optimistic that people are genuinely trying to help other people. Of course, there are always the folks who aren't and who have different motives, but I think most MDs in the United States have gone through so much schooling and training and have a real desire to help people do well.
What are your biggest worries in the practice of your business practice?
Government interference and insurance company interference. The two of them make it hard for patients to get the newest therapies, and for us to push the science forward and to be able to offer it to patients. There's always somebody getting in the way and making it hard for patients to access the best care. So to the degree that we can teach people about what the options are, and they can either come see us or they can take that information to their doctor, the better we do in our mission of helping and teaching.
What does it cost to repair a knee or replace a knee? Give me a little menu of costs.
Yeah, I don't usually share those numbers or have those numbers because they're so different based on what the patient's problems are, whether they have insurance that's going to cover the surgery center or the procedures, whether they need standard procedures or procedures that are outside the box. There's such a wide variation.
What's the range though, from minimum to maximum?
Oh, it varies all over the board because we see simple things that are very simple and we see very complex, complicated reconstructions that have been failed in the past and that we need to rebuild with lots of tissues and technology. So it's a pretty wide range.
How often does an orthopedic surgeon see the work of a previous orthopedic surgeon that didn't work out? How often are you repairing somebody else's not fixed repair?
It depends on your practice. So we have a tertiary referral practice, which means that I see patients from all over the world very commonly because something didn't work out somewhere else. And so we're seeing very challenging patients. But other practices are more primary care where they see the patient immediately off the field and have a more straightforward set of problems to address.
How much exercise does your average patient get? And you said you've had 100 milers, 200 milers. What's typical? How often are they exercising before they see you? You know, how common are they getting? How much exercise are they getting?
Again, I have an unusual practice. It's pretty bifurcated between world-class athletes and Olympians and skiers and sailors and folks who are coming in training every day. where their injury has interrupted their sport. And then weekend warriors, and also folks whose main sport is going to the mall, and they want to come in and be able to walk and not have pain when playing with their grandchildren. So I see the whole range. It's just our particular practice is a little more biased towards higher level athletes and people who have had really challenging problems.
So if you gave me those three categories, what's your percent of practice in super athletes, mild athletes, and non-athletes?
Oh, it's difficult to really give you accurate percentages there. The population, of course, are not super athletes, and so we see an awful lot of folks with common arthritic knees and torn meniscus and ruptured ACLs. So I don't have the percentages for you.
What's the most common accident of non-athletes that you see? Stepping off a curb or doing what?
Oh, we see people just getting out of a car and twisting their knee and tearing their meniscus. Yoga is a huge referral source because people go into deep flexion in their knee and tear their meniscus. CrossFit is another one where people are doing box jumps that they've never done before and land on their knees and shoulders and ankles, because I see knee, shoulder, and ankle, and we see all of those injuries from any of these sports.
So it's got to be gratifying to be in a game where you can positively affect the life of so many people. Tell me what puts the biggest smile on your face in your practice.
Oh, it's no question when an athlete comes back and brings us a picture or sends a video of them doing a sport they thought they'd never be able to do before, or winning a gold medal, you know, rebuilding an athlete months before the X Games and seeing them win X Games gold, as we've had a chance to do, is just one of the real thrills in the sport that we're in of orthopedic surgery.
So our guest today, Kevin Stone, is an orthopedic surgeon, MD. Kevin, thank you very much for sharing your knowledge, experience, and details about your practice in orthopedic surgery, modern orthopedic surgery, with the audience of the Wednesday Yachting Luncheon. It's been our pleasure to share this hour with you. Thank you so much for being our guest.
Pleasure to be here.
Thank you so much. And with that, the Wednesday Yachting Luncheon is adjourned.